slide, please. Page 7, please. That's okay. Yeah. For the personal updates, I would like to give everyone an update in regards to our Public Health Administration 2, which is our Genetic Disease Screening Program Division Chief. So currently, the applications are under review by our HRD and Center for Family Health. For the Public Health Medical Officer 3, this is actually the interview was coordinated by Center for Family Health, and they will have their first interview session next week. For our newborn screening section chief, so I actually participated as one of the panelists. So our program and policy branch chief, Cindy Wu, who is currently on vacation, and myself, we actually concluded our interview. So hopefully that probably from 4 to 6 weeks from now, we will have a new newborn screening section chief. For program development and evaluation section chief, so the interview has been completed as well. And there's a selected candidate, and it's currently under review by our HRD. And once that's completed, we're hoping that if all the MQs are met, that we will be able to provide a tentative offer soon. In regards to our program, the newborn screening, we will also have our fee increase coming up. So there would be a newborn screening regulation updates in July 1st of 2024. And the reason for the fee increase is because of the addition of the 2 new disorders, which is the MPS II and GAMT deficiency. There would be a public hearing coming up on June 24 to discuss about the fee increase and updates to our regulation. So that would be June 24 from 11 a.m. to 12 p.m. So there would be a notification that will be sent out by our communication education unit. So if you are part of our mailing list, you will be getting those invitations. So please feel free to attend if you have any questions about our fee increase, which is going to be, currently we charge $211 for any newborn screening that is tested in our program, and the new fee would be $226, which includes the $1 test precision form fee. Thank you.
Thanks so much, Emmylou. And we know that there are many things we all need to talk about, but this meeting is specifically going to center on our addition of MPS II and GAMT to our panel in a few weeks, starting on July 22nd, 2024. Next slide. And I thought I had, okay. I think Emmy went through this quick, but this is our agenda for today. We're going to start with MPS and then GAMT, and then Dr. Sharma and I will tell you about our program update. And next slide. And real quickly, for those who don't know, here in California, the way it works is we're what we call RUSP aligned. So we have California legislation that says that our California newborn screening program will test for all conditions that are on the RUSP, and that we will start testing within 2 years of their being signed by the Federal Health and Human Services Secretary onto the RUSP. So that means that we are required to test for these disorders. Happy we're going to be able to. Next slide. And real quickly, this is our timeline, how our program has grown over the past 60 years or so. And we're excited to bring up the new in 2024. So we have a very full agenda, and so we're going to get going with it. So I'm happy to introduce Dr. Paul Harmatz. Dr. Harmatz earned his medical degree from Dartmouth Medical School and completed residency at Harbor UCLA, followed by a fellowship in pediatric gastroenterology and nutrition at Massachusetts General Hospital. Prior to joining UCSF, he served on the faculty of Harvard Medical School for 12 years. He is now at UCSF Benioff Children's Hospital and specializes in mucopolysaccharidosis and other lysosomal storage diseases. And he leads a team of specialists who diagnose and care for these patients, as well as doing wonderful research into new treatments. Dr. Harmatz is a member of the Society for the Study of Inborn Errors in Metabolism, the Society for Inherited Metabolic Disorders, and the American Society of Gene and Cell Therapy. So welcome, Dr. Harmatz. I will bring up the slide.
Thanks, Tracey.
Yeah.
Really nice.
Yeah.
Dr. Harmatz, you should be able to share your screen now.
Yeah, well, he's with us, so it's taken me a minute to get into them, but I have them.
It's really an exciting day for the MPS world, and I know Terri Klein is following me, but I just want to acknowledge the immense work that the National MPS Society, families with MPS II, and really the mentors in this field, Barbara Burton and Joe Munzer. This was a huge effort. 6 years from the time MPS I was approved until MPS II, and I can tell you we have 3 more MPS that have approved therapy. I promised I would not retire till we have all 3 of those on, so if it takes 6 years each, I'll be pushing 100, so just be careful. Hopefully we'll speed up. We'll get all 3 at the same time. But Matthew Ellenwood is spearheading this at the MPS Society. Terri will, I'm sure, acknowledge his amazing role, but
Sona, do you want to stop sharing?
You want Sona to share instead? No, she should stop sharing. Okay. So that's Tracey.
so you might wonder how a gastroenterologist drifted off into mucopolysaccharide disease, and some of it is probably my ADD and inability to stay with a single field. I moved from GI to iron metabolism with Elliot Baczynski and worked with him on the toxicity of iron overload in his sickle cell thaw program. And then BioMarin around 2000 was looking for a site to do their first phase 1 trial for MPS 6, and they came by Oakland Children's, and Bert Lubin, who headed the PCRC, came to me and said, "Are you interested?" It sounded really fascinating. I had not done much industry work, and I was able to pull out of half of my GI at that point and take over the MPS 6 trial. And then I sort of learned the field from Lauren Clark, who was leading MPS I, and Joe Munzer. I was always the third speaker, so there was MPS I, II, and 6 on all the lecture circuit in the first 10 years, so I never had to do any of the genetics or basic biology. They had already presented, and I could just focus on clinical studies. But that's a little bit of the history. It just grew out of that start, and since then we've worked with trials in virtually all the MPS, 2, 3A, 3B, 4A, 6, and 7. MPS 1 is the one area, and now I'll mention the trial that will be coming to UCSF for MPS 1, but Sandy and Carbanda will be heading it. She's the transplant person at Mission Bay, the West Campus, and we'll work together on a a gene therapy for MPS I. It looks extremely promising. So these are my disclosures. This is the family of MPS. You could say it's one area, but it's 13 different diseases. They each have a different genetic gene that's mutated. They have some similarities. The common characteristic is they all have storage, excess storage, inability to break down glycosaminoglycans. So it's the storage material that drives the disease, and the mutation leads to the storage. This is the glycosaminoglycans are shown in this picture. It's a polysaccharide, hence the mucopolysaccharide name, and it's attached to a protein backbone. So another name is proteoglycan.
I'm sorry, we can't see the slides that he's talking about.
Okay. We'll work on that. Good information.
I can see the slides. Oh, I thought this was...
So these storage molecules do more than just fill lysosomes, make the cells swell and fail. They really are vital for many of the cellular function. If you read the new reviews on glycosaminoglycans, you're amazed at the cell receptors on the surface, the communication between cells, the structural framework they provide for cells. All of these are part of their basic biology. So, but can you see the slides now?
Yes, we can.
Okay.
Yeah, we're not forwarding, so we're stuck on this. Okay. Hopefully the arrows will work. This is the classic table that we use to describe all of the MPS. The interesting thing is you now have 3 new MPS. At the bottom, you can see 9, 10, and MPS plus. These are extremely rare, and probably you'll never see those diseases. But the top 6 are really should be in our sort of diagnostic acumen. If we see some of the features of MPS, there are easy ways to arrive at diagnosis for any of these diseases. And we've struggled with education since I've worked on virtually all diseases. We've had educational programs. We try to target clinics, but ultimately, and I'm quoting Joe Munzer, the newborn screening is going to be the only way that we get these patients identified effectively before they have severe disease. And we fundamentally have learned that once we have the brain disease, it's very hard to reverse or to put a patient back on a normal curve. So the key is to identify early. Here we're talking about the MPS II Hunter. It has gene as IDS, complicated gene. It takes a real expert to do the mutation analysis, and the storage material you see on this side, the dermatin and heparin sulfate, are key to the disease manifestations and are very important to note when you're trying to make the diagnosis. Okay, we got it. So showing a picture here, this is my mentor in MPS disease. Most of you hopefully can recognize Joe Munzer. He's almost the same age as I am, also moving towards retirement, but I should say that he's setting up an institute at the University of North Carolina for the clinical and research of MPS disease, training young physicians. It's going to really be an amazing facility. So, but MPS II, we know multisystemic, it's progressive. It's the only X-linked MPS disease, so very different genetic pattern. We look for mostly males, and we look for uncles and grandfathers. We're likely to find a good pedigree that will help trying to determine what phenotype this patient has. It has early mortality. The estimated frequency 1 to 100,000 to 170,000 births. We'll see what we get in California. In Illinois, it's over the last 5 years, Barbara Burton reported about 1 in 70,000. Half were attenuated, half were severe. So it'll be interesting to see what happens in California. It leads to the accumulation of heparin and dermatan sulfate. The heparin is thought to be the brain toxic material, dermatan somatic toxic material. These are sort of patterns from the other MPS. There are some that have only heparin and primarily brain disease. There's some that have only dermatan. They have normal cognitive function and have somatic disease. So it's this group of patients here, the patient that Dr. Munzer is handing over gave a lecture at a genetic counselor educational program. He has attenuated disease, but you can see, even though Joe Munzer is quite tall, patient is short, has a lot of the skeletal features, pulmonary, the cardiac, all are part of his picture. So 2/3 are severe, 1/3 are attenuated, of early death in the severe patients. The next two slides just summarizes the organ systems that we have to be aware of, and it really is. I had to go out and buy a stethoscope when I moved from GI to taking care of MPS patients. I had to listen to the heart and think about pulmonary function and look at skeletal problems, and then the CNS is quite important. We have hydrocephalus, we have developmental decline, we have cervical compression, all part of the disease picture. The previous slide noted carpal tunnel is present in virtually all of our patients, and if you ever have a child with carpal tunnel syndrome, you have to think MPS. And hearing, very important in a young child. Dental care is important. The enamel is defective as part of their mucopolysaccharide disease. They have a lot of dental caries and failure of eruption and need a lot of help from interventional dentists. We don't see corneal clouding. I don't have an explanation. It's so predominant for MPS I. There's also dermatan heparin storage, but in MPS II, the corneas are clear, but they do have a retinal generation that can be a major problem in the teenage and 20s, and difficulty with night vision and driving, those type of things. So, slide. This is giving you a picture of a real patient. It comes from an article from Mauricio Scarpa, and the patient was one of Joe Munzer's patients. So this is a 14-year-old, and you can see the dramatic features. He has the coarse facies, which, the bushy eyebrows, prominent orbital ridges, flat nasal bridge, broad nose, abnormal dentition. And then you move down this, you can see the large liver and spleen, the skeletal abnormalities, the dysostosis multiplex, which is the skeletal feature, the broad elbow and wrists, and I'm sure he has an abnormal spine. This disease, you have to keep in mind that there's a tremendous range of severity, all the way from the most neuronopathic, somatically affected, to a very attenuated form, where we actually had one patient who was a double black diamond skier and a gourmet chef, and is in his 40s now. So it's broad spectrum, makes the clinical trials quite challenging, and it changes over time. So the child at 6 on the left is sitting up and obviously has neuronopathic disease and features of MPS II, but then by 12 years of age is severely affected and bedridden and sort of end stage of life. So it changes with age, it changes with patient. And then our attenuated patient that I showed you earlier, these are 2 pictures when he's younger and then as an adult. So next slide. Mauricio Scarpa and a committee in Europe put together recommendations for care, diagnosis, and treatment of MPS patients in 2011. So basically the diagnosis, this is before newborn screening. I'm not trying to adapt screening into the process, but we would see a patient that had clinical features. Now you would screen urine. In the old days with dye-binding urine assay, we did it, but it was harder to quantitate accurately, and you needed electrophoresis to find this different species, which took a highly trained lab and was very qualitative. Now the tandem mass spec lets us really identify the types of GAG storage and how much of each of the GAG, very accurate. We still consider plasma enzyme as the gold standard. I know it's hard to convince geneticists not to send whole exomes or whole genomes for these patients. Really, you can drive this from a clinical picture all the way through diagnosis. But now we will do the molecular. It helps with phenotype prediction. It helps with prenatal diagnosis. You'll need those pieces of information. Natural history, it's hard to get natural history once you start enzyme therapy. Neurocognitive, since it's not being effectively treated, we do have good natural history studies, and Ilse Shapiro is sort of the grand dame of MPS neurocognitive testing, and her mentee, Julie Isengard Schoen, have put together tremendous studies. And this was a review of I show 3 of the previous MPS II neurocognitive natural histories. And you can see normal going up in black, and then 3 different studies which show that the first couple of years of life, you do gain skills, but at a slower rate than normal. Then you plateau, and then you start declining. And we recognize that if you're below -2 standard deviations from normal on the cognitive development, it's very difficult to get back on a curve that shows positive gains. So we have to, you're helping us push this back to a treatable disease. So nice comparison. When I started MPS work in 2000, we had a lot of supportive therapies. The only specific therapy was stem cell transplant for MPS I. People have tried it for other MPS. It can provide enzyme, but it hasn't really been compared to enzyme therapy at the same age. It's certainly an alternative in an area where enzyme is not available. So in 2022 or 2024 now, I haven't updated, I should. Probably the biggest changes with supportive care, the recognition we need a multidisciplinary team. We need centralized surgery for the really complex surgeries. We need anesthesia. If I had to pick one, the first person, most important person on a clinical team, it's your anesthesiologist. And in the old days, it was intubating and fiber optic skills were essential. Now you really have to be aware of blood pressure and preventing secondary complications. Spinal infarction, which is really your most feared complication. You go for a knee surgery and you end up with injury to the spine. So, but we have enzyme therapy. We have specific therapies for now FDA approved for 5 of the different MPS, and we have a much improved transplant. The last 20 years of really change the morbidity and mortality of transplants. So, next slide. Just how do these enzyme therapies work? They work by cross-correction, and the person that really broke through this field was Elizabeth Neufeld, shown in this slide. She is the grand dame of MPS disease, and she had a postdoc who was working with Hunter and Hurler fibroblast cells in culture, accidentally mixed the two, and they looked at the cultures and there were no storage at that point. So they quickly recognized, fortunately, that something was being secreted from each cell that's correcting the opposite cell, and that's called cross-correction, and it's really the basis of therapy. We don't have to either treat genetically every cell, we don't have to, we just need some cells producing the enzyme in the body, or we have to give it to the body by IV infusion, goes to the cell, gets absorbed by the binding to the mannose-6-phosphate receptor, goes to the lysosome and digests the GAG. So very fundamental. She made the breakthrough. Neufeld is now retired. She moved from NIH to UCLA, stayed very active into her 90s, but has retired now. But this just shows some data from Scarpa's paper, but it's the basic clinical trial, the phase 3/2/3 trial for idursulfase, and the graphs have been simplified. There was an every other week group that was not very effective. So here's comparing weekly to placebo. You can see the walk test shows a great difference. The FVC on percent predicted almost was different, but if you measure the absolute change in expiratory volume, you see a very significant difference. And the urine GAG shows a very rapid disappearance, which is what we would like to see. Now we have approved therapy for MPS II, idursulfase.
Giano, can you put in order?
2005, EMA in 2006. We are so happy we have newborn screening now. It's a lot of work, and I think it was slow because people were waiting for a specific brain therapy, but we're very happy to have these patients receive therapy early and have better quality of life and the promise of some of the new therapies. So this just shows the difference in early treatment. SIB studies are really a great help with early treatment. So we have a brother treated at 4 months. His older brother started at 3, and then followed for 2 years, 2 to 3 years, and you can see the difference after 3 years of treatment. Of course, facies remains in the older brother. It's not visible in the younger, and then the comparisons are quite remarkable. And even the comparison of the neurocognitive testing, the bottom line, you can see that after 3 years, the older brother is 42, the younger brother is 74. So there's probably an effect on the brain. We don't know if it's a small amount of enzyme going across or just better health overall, or somehow a concentration gradient reducing the CSF storage, which is Patty Dixon showed that directly for MPS I. I'll say a couple of words. I don't know how 2 more minutes. We're over time. The 2 areas of therapy that I would highlight, these are all possible strategies for improving therapy, but blood-brain barrier penetrating proteins are in active trials, phase 3 trials. Gene therapy has completed a phase 3. We're waiting for submission and reviews. Next slide. So there are two different programs, both testing an enzyme used to a molecule that binds to the transferrin receptor and then moves inside the brain. And these studies are phase 3. They take a long time to complete. We're required to do a functional outcome, which takes years to really demonstrate a difference between treated and untreated groups. They'll also look very carefully at heparin sulfate as a biomarker in CSF. Next slide. This is also a SIB study. You can see two brothers, SIB1, SIB2. Older brother only got idursulfase, and that's the blue line. Younger brother got idursulfase a year earlier, but then switched to the brain-penetrating enzyme, and you can see the younger brother is following a normal curve for 4 years, and older brother follows the curve. Shapiro's natural history graphs. Next slide. Gene therapy, we have two types in mind. We have in vivo, where we inject a gene that's packaged in a virus. We can place it in the bloodstream or inject it in the spinal fluid. And then the ex vivo, we take cells, stem cells from a patient. They're sent to a central lab. They're modified, gene edited. They come back to the patient, and the patient needs conditioning, but then they feed their own autologous stem cells back. Right. We have two trials, one with the in vivo that I described to you earlier. Patients were 4 months to 5 years. It's finished its phase 3, and we're for submission and positioned. And then a very exciting ex vivo autologous transplant just starting in Manchester, UK. They're using their editing with a idursulfase and an ApoE2. The ApoE2 acts as a transport molecule, and receptor binding molecule. So you get both stem cells moving around the body, and you produce a lot of enzyme that can move to the brain. So age range is quite difficult, 1 month to 1 year. They'll accept people worldwide. So if anyone has patients that are interested, we're happy to talk to them about this study and Manchester groups. Finishing by acknowledging particularly all our patients and families who participated in these many trials over 20 years. Clinical and research teams, 5 or 6 of them are here today. Sponsors for these trials, the advocacy groups that have helped move the trials along, provide education and support and research money. Thank the state for bringing up this exciting new therapy and new diagnostic tool. Thank you.
Thanks so much, Dr. Harmatz. I think I'm going to make the decision to hold all questions until all speakers. So hold on, folks. Yeah. I will. Okay, so I am not sharing anymore. I'm happy to introduce our next speaker, Terri Klein, who is the President and CEO of the National MPS Society, and she has spent 2 decades in rare disease advocacy. She's a board director of the International MPS Network and a founding member of the Mucopolysaccharidosis Research Collaborative Network. Graduate degrees are in public administration and nonprofit management, and in addition to oversight of the society, her initiatives include health equity issues, drug development, and numerous rare policy issues. She's also the mother of Jennifer, who's been diagnosed with ML3. So, very happy to welcome Terri Klein, and I see you're sharing your slides. Can we hear you, Terri?
Yes, you can hear me, and it's good that you can see the slides. So thank you so much. It's an honor to speak with all of you today, and thank you, Dr. Harmatz, for that wonderful overview of MPS II Hunter syndrome. As Dr. Harmatz had shared, sending a nomination into the ACHDNC for consideration for newborn screening is not for the faint of heart by any means. And I've been here since we submitted the MPS I nomination, and now here working with Dr. Matthew Ellenwood, who has spearheaded the MPS II nomination with us, and some formidable positions and geneticists, as Dr. Harmatz had shared with you. it's a collaborative and it's a team effort. And it's amazing that these types of efforts do land with the patient advocacy group in order to bring forward, but it helps to expose another layer of what we do. My goal today is to tell you a little bit about us, what we do as a patient advocacy group, and what happens after newborn screening or during the newborn screening process. How does the patient advocacy role play a part in that newborn's life? And I also want to say thank you to California. You lead, your health department leads the country in not only having important legislation around the newborn screening, but also including the timeline, the critical timeline of adopting the process of screening the babies. And you are a beacon. You truly are a beacon for other states as we bring states on one by one. So thank you for your efforts in advance. Thank you for being so forward thinking. See if I can get the slides to shift. The National MPS Society it's a fantastic organization. One of the areas that we lean into is what we call family support. And in our organization, we actually have 3 full-time social workers that work with us. They travel the country and they meet with families at the time of a diagnosis of MPS or ML. So at the time of a Hunter diagnosis, our social workers meet with these families face to face. We started this program back in 2017, and serendipitously with the onboarding of MPS I and now MPS II, little did we know how critical this was going to become for these families. It has changed everything. We always had telesupport, right? Over the years, this is what our best practices were. But by bringing social workers on staff with us, they're able to navigate the areas and the ecosystems of our families and the struggles that they're facing, even if it's beyond Hunter syndrome. What is it that they're needing to look for resources in the community? And so we have a plethora of family support programs, as well as this Treasured Pathways program. And I wanted to share that information with you. Oftentimes, it is from a health department that is providing the information to the primary care physician or a geneticist that there is an immediate call over to the National MPS Society. But I would be remiss if I didn't say that our hope is that you will put in as a resource, not just only our National MPS Society, but Project Alive as well, because they are a support group that also supports Hunter syndrome. And so if our families can land with a patient advocacy group, or we want to be able to work with them to help educate them more about Hunter syndrome, this will propel them into spaces quickly, because it is a devastating diagnosis. We've had a lot of learnings from MPS I and the prenatal diagnosis of MPS II. And at the Society, we're constantly moving towards improving the resources. We are one of the organizations globally that has a library of resources for pamphlets, booklets, even up to 180-page resource guides for each of our syndromes that we have reciprocity on with other countries, because our goal is that these materials do get shared with families. So we lean heavily into those educational resources and ensuring that the Hunter families, our MPS II families, will be equipped very quickly with as much information as they possibly can absorb, and then continue to follow with their educational needs. That's been an important stepping stone for our families to come into the diagnosis, knowing how devastating it is, and moving from that devastation towards reading and learning about how they're going to be able to care for their loved one. And we want to make sure that everything we have is available to them. The Pathways program that I talked to you about is unique. We did not know another organization, and we still do not know another organization in our country that serves families in this way. So that when we have a new diagnosis, we're usually with that family within about 3 to 6 weeks, somewhere in that time frame, when we can work out our travel schedules with that family. And it's changed everything. When our Pathways program is full, I have the honor of stepping in to help them. And one of those families was a newly diagnosed Hunter family in North Carolina, where I was out with them at the hospital during one of their first infusions a few weeks back. And I recognize that I didn't have that type of support when my daughter was diagnosed in 1999. So knowing that we can bring this different level, it changes a trust relationship. It takes us from just a patient advocacy group to truly part of a team member for that family and their ecosystem, so that they recognize that they can lean to us so that we can help them navigate a new territory that they're in. And it is just devastating. Besides the resources for the Pathways program, we offer also, just so you know, a plethora of other programs throughout the journey of a child that has MPS. Some of those happen quickly, right? You're in the newborn screening arena, so you're testing babies, but recognize too, in our space as an advocacy group, as Dr. Harmatz shared, we only have 2 disorders that we're screening for right now. And so we support 12 disorders, and now as he disclosed, a 13th one, extremely rare. But we're an umbrella organization, so many of our families that are reaching out to us, it's beyond the infancy, right? It's into later years, because oftentimes the MPS disorders, the symptoms manifest slowly, and they come forward at the age of 2 or 3 or a later onset of maybe 6 or 7. We just worked with a family that was diagnosed in North Carolina with MPS I that's 64 years old. And so these diseases are not just pediatric based. There is a spectrum of the disorders. But as Dr. Harmatz showed all of us, being able to diagnose a baby at birth is absolutely critical in terms of being able to provide the most optimum quality of life when we have a life-saving therapy like we do. And we have options for potential clinical studies that is going to change everything. So capturing those babies at birth, like we did here through a pilot study in North Carolina for this Hunter child, it will change his trajectory of life, and it is a good thing. I come from the generation of where we didn't have adults going to our family conferences in the late 90s and early 2000s. There's very few adults. But now with these therapies, we're seeing an absolute increase in the adult population. Now imagine what will happen as we take these therapies and move them into the babies. And so you're doing just some incredible work. But no, on our end, we have therapies. We have programs that span the entire journey. Many of the programs will move from various granting programs. Right away, our families become members. There's no cost for membership, but they become involved, and families are eligible up to $3,000 per child per year, knowing that these are genetic disorders, and oftentimes families may have more than one child. And so we offer $3,000 per child per year, and sometimes even more in other programs. We also have a very I don't want the cohesive or very special, I'll call it, bereavement program. We have many families who have lost their children to these disorders, but they still want to be connected in some of the mission work that we do and serve, because we do a lot of advocacy work on Capitol Hill, and we are integral into critical rare disease legislation and rare disease rights and inclusivity, and moving in our DEI programs, that many of these families want to have that power. They want to be able to take back an advocacy control because they've lost their child to this disorder and they want to do more. And so our bereavement programs are quite expansive. We also offer college scholarship education, college scholarship, and also conference scholarships. Our college scholarships, we offer almost $50,000 a year, not just to those with MPS and ML, but also to their siblings, because we recognize the families are financially impacted as well, and we want to raise those siblings up. This is one of my favorite slides that my colleague Leslie Ordonata put together for you, and Leslie would have been here today, but she's out, and so I'm thrilled to be here talking to you. But this is one of my favorite slides that she's actually put together a few years ago that she updates when we need to. But it's all about access, right? It's all about access, because access means inclusivity. It means that we're able to reach the patient population where they are, and we stay focused on this in all of these areas, from medical, clinical, financial, treatment options, our case coordination, all the way through our emotional, mental health issues that we're struggling through, and of course, our care management. And when you look at those blue dots, someone once had said to me, they said, well, which one tends to fall away with a family? It is hands down emotional mental health. Our families tend to put this last and not first. And we recognize that they need to be able to bring this a little higher up on their priorities too. And we need to help them, because until they're strong and they're well and they're able to manage, will they really manage and be able to fire across all of these other areas? But it's our role as a patient advocacy group, and it's Dr. Harmatz's role as a physician to ensure that our families have true, genuine access to these areas, and that they're identified and they're acknowledged, so that families aren't always in the dark. We don't want them to be feeling as if they're alone. The goal of a community and a patient community like the National MPS Society is to bring others together. And so we do host webinars. We host 1 to 2 webinars a month, whether it's in family support pathways, grief management. Dr. Ellenwood is going to be launching the new Ask the Doctor podcast in 1 month. And so it'll be able to talk to him about the different research and science that's happening, the clinical studies that are going on, because we're trying to be as accessible and optional as possible. As well as this year, we'll have that full translational conference, meaning we're going to be translating into multiple languages this year, as well as streaming it to families who can't come in person. Thank you. On behalf of everyone here at the National MPS Society, Dr. Matthew Ellenwood, Leslie Urdanata, myself, all of the clinicians and geneticists, Dr. Harmatz, you are leading the nation in newborn screening for Hunter syndrome, and it is not going unnoticed. It's noticed. States need to see the courage and the bravery of California having this type of legislation front and forward, so that they can also work with their own coffers, with their own state budgets, to try to bring screening forward. You will be responsible for changing the lives of those impacted by MPS and Hunter syndrome, and it will be for the better. So thank you.
Thank you, Terri. We appreciate it. And again, I'm going to move forward in the interest of time. We started late and we've had some great presentations. So we're going to switch gears and move to GAMT, or Guanidinoacetate methyltransferase. And I'm extremely excited to introduce Dr. Nicola Longo. Dr. Longo received his medical degree and PhD in molecular biology at University of Parma in Italy. He completed his residency and fellowship at Emory University in Georgia. And in 2001, he moved to Utah, where he worked to develop a metabolic clinic at the University of Utah. And he worked at AREP Laboratories with his wife, Dr. Marzilia Pasquale, to develop an assay for GAMT. And their work has led to GAMT screening in Utah, New York, and Illinois. And eventually, the condition is now on the RUSP. In California, we're extremely lucky that Dr. Longo has recently, this summer, taken a position as professor and vice chair of human genetics and chief of the Division of Medical Genetics at the University of California, Los Angeles. So we're very happy to welcome Dr. Longo, and he's going to present his slides.
Can you see them? Full screen?
We can see them here in the room. Can others see them?
Yes, we can see them on screen. Thank you, Dr. Longo.
And it is full screen, is that correct?
Yes.
Perfect. Thank you very much for inviting me to give this presentation. And what I would like to do is really to present what GAMT is and why it is important to have this condition on the newborn screening panel. I just joined UCLA after more than 20 years at the University of Utah, and here are my disclosures, none of which is relevant to what I'm talking about today. So the first thing to understand is that GAMT deficiency is a disorder of creatine synthesis. And we need to understand a little bit what creatine is and what creatine does. And I apologize for many of my colleagues who are in attendance who know 100% what I'm going to talk about. But creatine is necessary for energy utilization. Creatine is part of what we eat. It is mostly present in meat and dairy products. It is not present in vegetable. And the function of creatine is really the one to shuttle energy from the place where it is produced within mitochondria to the cytoplasm where energy is utilized. Without creatine, all of the processes requiring energy take place much more slowly. And that it is why its deficiency results in significant clinical symptoms. Now, again, we obtain most creatine from the diet, about 50%, and we also synthesize creatine from our body is able to synthesize it. Now, why do we need to continue to take creatine? Because creatine and phosphocreatine, which is the, let's say, the active compound of creatine, the one that carries energy, are degraded into creatinine, which is excreted in urine and eliminated. Obviously, what we have to do with the body, we have to replace the one that it is lost to maintain the body capacity to handle energy. Now, how do we get creatine? So there are two enzymes, one which is called AGAT, or arginine glycine amidinotransferase, which from arginine and glycine synthesize guanidinoacetate. The second reaction is the one catalyzed by GAMT, guanidinoacetate methyltransferase, that convert guanidinoacetate into creatine. At this point, creatine needs to reach all organs and tissue and does so through the action of a specific creatine transporter. It is important to realize that this creatine transporter is also the one that reabsorbs creatine in the kidney. If we lack this creatine transporter, we leak creatine in urine. The disease which is the subject of today is caused by the deficiency of the second enzyme, which is called guanidinoacetate methyltransferase deficiency. Now, where is this enzyme? This enzyme is in many cells in the body, but it is very highly expressed in the liver. So in general, instead, the other enzyme, which is the GAT enzyme, is most expressed in the kidney. So physiologically, the AGAT enzyme, which is expressed in kidney cell mitochondria, will synthesize guanidinoacetate that will travel to the liver, that will be converted into creatine, that will reach all organs and tissue by the action of the creatine transporter. There are several other transporters that can transport creatine, but with a much lower efficiency. Now, as you have seen, creatine is synthesized in the kidney and the liver, and it reaches all organs, but most of the symptoms of creatine deficiency are from the involvement of the brain. Why? The main reason is that the amount of creatine that the brain needs is higher than other tissue. So the brain needs both activity of the creatine transporter and endogenous creatine synthesis. Creatine can be synthesized in the brain to be fully functional. Other organs, they can rely only on one of the two, and that is why the brain is more affected than other organs in brain creatine deficiency syndrome. Now, what are the symptoms of brain creatine deficiency syndrome? Intellectual disability is universal in all the creatine deficiency syndrome, deficiency of AGAT, GAMT, and the creatine transporter. Speech delay, behavioral problem with autistic-like features are all present in this patient. Seizures, they are more frequent in GAMT than creatine transporter deficiency, and movement disorders are more prevalent in GAMT deficiency. Muscle involvement is more prevalent in AGAT. Remember, all of these happen in all of the diseases, but some of them have more clinical manifestation. There can be changes in the basal ganglia in GAMT deficiency, even though in most cases, the brain MRI itself is actually normal. Failure to thrive and reflux is more frequent in creatine transporter deficiency. All of these conditions are called cerebral creatine deficiency syndrome, or CCD. Why? Because they were initially identified by the lack of creatine peak by magnetic resonance spectroscopy. This is different from MRI. MRI shows the structure of the brain. Magnetic resonance spectroscopy can measure the concentration of different chemicals within the neuronal cell in the brain. And you can see in this spectroscopy from a normal control that the main peaks that one can see are N-acetyl-aspartate, creatine, and choline. In the creatine deficiency syndrome, the creatine peak is absent or markedly reduced. And that it is one of the characteristics which is the same for all creatine deficiency syndrome. Remember, this is not the same as MRI, meaning that if you do MRI, you don't measure the chemical. It is a test that one needs to expressively request for measuring the creatine. It is in addition to the MRI. Now, there are also other ways of diagnosing this condition, and there are actually guidelines published by the American College of Medical Genetics on the testing that it is necessary. But let's go back to that. So what do we see in this condition? In AGAT deficiency, when we look at the plasma, we see low level of creatine and guanidinoacetate. In GAMT deficiency, we see low level of creatine with very high level of guanidinoacetate. In the creatine transporter deficiency, plasma levels are usually normal for both creatine and guanidinoacetate, but there is a very high creatine to creatinine ratio. So when we see the low creatine peak in the brain MRS, and then we see this abnormality, we like to confirm the diagnosis by DNA testing, keeping in mind that some of the patients have mutation outside the region that it is normally sequenced. So some of the mutation might be missed by genomic sequencing, simply because we still do not know what all of the DNA does, and we don't have the ability to identify all of that. But more than 90% are usually available. In those cases, functional testing is theoretically available, not really easily, mean that you can measure the activity of the enzyme or creatine transport to confirm the diagnosis. Now, I'm going to review briefly also the other syndrome. AGAT deficiency is the deficiency of the first enzyme on the pathway, and this result, it is the most rare of all of the three creatine deficiency syndrome. It presents like all other with intellectual disability, and weakness and muscle involvement are more prevalent in this condition as compared to the other two. And the therapy is by giving creatine at high dose, obviously early in life. This would be another great candidate for newborn screening, and patients treated early are pretty much perfectly normal. Patients treated late, they have a great improvement in the development and the muscle tone. But again, the therapy needs to be initiated before brain damage. Now, how do the level of creatine and guanidinoacetate look like in this patient? And these are data that are from ARUP laboratory, and they were provided by Dr. Marcia Pasquali. And you can see in pink that the level of guanidinoacetate are very low in this patient, as are the level of creatine. They are low this is in plasma, they are low in urine as well, but there is significant overlap in the urine between the normal control that are the black dots and the patient with AGAT deficiency. So one needs to measure activity, the level of this chemical in plasma, not in urine. Urine can provide a false negative result. But let's go back a second to GAMT deficiency. This was my very first patient, and she presented at 6 months of age with delayed development. And at 1 year of age, she was severe low muscle tone. She could only blink her eye, and she could move very, very little. And at 2 years of age, she developed seizure. And this was the time when they did a brain MRI. And at the time, the center I was working with was doing magnetic resonance spectroscopy pretty much on every kid. And you can see that at time of diagnosis, the level of creatine was very low in the magnetic resonance spectroscopy. At the point, the patient was referred to us, and we did biochemical testing to confirm the diagnosis. But just to refresh your memory, in this condition, this enzyme is defective. For this reason, what we see an elevated guanidinoacetate, and because this accumulates before the enzyme that it is defective, and the reduced level of creatine, which results in decreased supply of creatine to the brain. This slide summarizes a little bit what we know about GAMT deficiency. It's still extremely rare. We are putting an incidence that on 1 in 500,000. We do not know the exact incidence. We think that it is about 1/2 as frequent as creatine transporter deficiency, but we don't have a firm frequency. We need states like California to add this with the newborn screening to get a true population-wide incidence of the condition. So we have discussed the presentation, which is again intellectual disability, seizure, and autistic-like behavior. Some of these patients develop abnormal movements as well. And we have discussed the diagnosis. What is the therapy? We need to give creatine at high dose to replenish the creatine, but also guanidinoacetate, which is the chemical that accumulates here before the metabolic block is toxic. The very first few patients were treated only with creatine supplement, but they still continue to have severe delays and their disease progressed despite the administration of creatine. And that is why we need to try to reduce guanidinoacetate. How do we do it? So the way that we do it, this is a biochemical reaction. In biochemical reaction, you can reduce the formation of this one by reducing the concentration of the precursor, which are arginine and glycine, and by increasing the concentration of ornithine, which is the other product of the reaction. And that it is exactly what we do. So we give some limited protein restriction to reduce production of guanidinoacetate and arginine. We also sometimes provide sodium benzoate. Sodium benzoate binds glycine to produce uric acid that it is excreted in urine. And then we give ornithine supplement, usually at a dose which is similar to the one of creatine. What happens when we do that? Obviously, we cannot reverse brain damage. Still, even if patients are treated late, there is significant improvement on how patients do, and especially in seizure control. But again, the brain damage that has occurred cannot be reversed. At the same time, if we start therapy in the newborn period, and this has happened with siblings of previously diagnosed patients, and also with patients diagnosed by newborn screening, their development remained completely normal. And now we have people who are, teenagers. So, and again, we know that they're doing fine and that intellectual disability is totally prevented. They go to normal school and they do pretty well in school. Now, let's go back a moment to see what we see in terms of biochemical finding. And you can see that the creatine level are usually low, but again, they might not be terribly low, but they're usually low. And the guanidinoacetate is always very elevated. So this is the only constant thing. I don't put the data in urine here because I do not recommend testing urine in this patient. I recommend testing plasma. And here are the data in plasma. You can see that there is no overlap between the level of guanidinoacetate in this patient and normal control, which are the black dots. And the creatine is low in this patient, but keep in mind that at birth, that can be overlapped because creatine goes from the mom to the baby to the placenta, and it can be pretty normal in newborn with this condition. And you can see that there is a big overlap when you study urine, creatine, and guanidinoacetate. So not necessarily you can identify this condition by studying urine. With therapy, what we do, we can reduce guanidinoacetate, but not to the normal range still. And creatine, we try to keep that above the normal range. Again, plasma is the most informative specimen for diagnostic purposes. Do not test urine, test only plasma. So what is the most important thing to do? So you reduce guanidinoacetate by giving creatine a little bit, but mostly by limiting the concentration of glycine, which is the thing that it is sometimes underappreciated. And that's why we tend to push sodium benzoate that reduce both glycine concentration and guanidinoacetate concentration. So what happened with time? We are able to increase the creatine peak in the magnetic resonance spectroscopy. It doesn't normalize, but still get better. Again, the outcome tend to be close to normal when the therapy is started before there is irreversible brain damage. And that it is why this condition was an ideal condition to include in the newborn screening. Which data were provided to start the newborn screening? These are data that were generated at the beginning with what we had. And you can see that again, the guanidinoacetate in blood spot is consistently above normal. The creatine again can be pretty normal at a few days of age. And with time, it goes down below normal. But do not rely on creatine for the diagnosis. Just follow what happened with guanidinoacetate. The only other condition that we know that can cause elevated guanidinoacetate at birth is arginase deficiency. So give a second look at the plasma amino acid in case guanidinoacetate is elevated and it is not GAMT. So we started looking for GAMT for a long time, back in 2015. The false positive rate is very low. And once New York started, they even introduced a second transition to measure creatine more effectively that further reduced the false positive rate to almost zero. So try to see a moment what was published by the second paper in the state of New York to have very low false positive rate. The last condition is creatine transporter deficiency, which is X-linked. Most affected patients are male, and you can see that the creatine peak is very low in their brain as well. And they tend to have the same clinical presentation with seizure and everything. This is the only one which is diagnosed by measuring urine, where an increased urine creatinine ratio. And for this one, unfortunately, we still do not have a therapy that helps everybody, even though some patients respond to high level supplementation with creatine, glycine, and arginine to promote the synthesis of creatine in the brain. So in summary, defect in creatine metabolism and transport result in the intellectual disability, hypotonia, and seizure. AGAT and GAMT deficiency impair creatine synthesis, whereas the transporter deficiency impairs the entry of creatine to the brain. The diagnosis requires the measurement of plasma and urine creatine and guanidinoacetate, and the therapy consists in creatine administration in all of them with supplement of ornithine and benzoate in GAMT deficiency. And in the creatine transporter deficiency, there are other possible measures. So thank you very much for your attention. I want to thank all of the people who work on this project, both in the Division of Medical Genetics at the University of Utah, at ARUP Laboratory, but most importantly, all patients and family with creatine transporter deficiency, GAMT deficiency, AGAT deficiency, and the Association for Creatine Deficiency. Thank you.
Thank you so much, Dr. Longo. And I am going to hand it over to Kim Tuminello, who is a co-founder of the Association for Creatine Deficiencies and currently serves as Director of Advocacy. Her passion for these rare diseases comes from her own children being diagnosed with GAMT. She's a graduate of San Diego State with a BA in Communications and has over 25 years of sales management and recruiting experience. She has taken her passion for helping children with creatine deficiencies to the state and national level in her advocacy work. She resides here in California with her husband and 2 children, Ty and Paige. So I believe we've got our slides up. Excellent. Kim, are you ready?
I am ready. Thank you very much. Dr. Longo, thank you for that presentation. That was great. As always, we really appreciate you. Thank you all for having me here today. I really appreciate it. I think California, I'll reiterate what Terri said, is really kind of leading the charge with getting GAMT on and newborn screening of those that have been passed by the rest quickly. So thanks to California. I will share with you my journey of GAMT and my family story. And hopefully you will have all learned quite a bit about it by the end of this session. So to start off with, yes, my name is Kim. I am a mom of 2 children with GAMT. I will take you through their journey. My son is now 18. He is about to be a senior in high school. And my daughter is a 14-year-old, about to be a sophomore in high school. And they have 2 very different stories based on their time of diagnosis. Next slide, please. I won't go in too far. I think Dr. Longo did a really fantastic job of talking about the different types of creatine deficiencies, but the Association for Creatine Deficiencies, also ACD, we do represent all 3 of the different creatine deficiencies, 2 of them having a treatment, AGAT and GAMT, and then creatine transporter disorder, which we are working very hard in making sure that we find a treatment as quickly as possible for these kiddos. Next slide, please. This is a slide that kind of shows what the clinical symptoms are. As you can see, 97% of our kiddos had speech delays, gross motor delays, 92% of them, and seizures, all very prevalent, and also hypotonia. This is for kind of across the board for all 3 of the creatine deficiencies. I know it looks a lot like all of the other rare disorders that are out there, but these are definitely the hallmarks of cerebral creatine deficiency syndromes. And certainly GAMT falls right into that also. Next slide, please. These are my 2 children, Ty and Paige. And the story goes with Ty that, really his symptoms started off as being hypotonia. He was not able to sit up. He wasn't able to feed himself or bang blocks. And when other kids were pulling themselves up into a standing position, Ty was limp. He could only lay down. He stopped rolling over at a certain point. We thought that he just wasn't getting enough food. He was on the 0 percentile. weight gain. And so I stopped breastfeeding, and he's just continued to get worse and worse. We went through a series of tests that you can imagine, from EEGs to EKGs, blood tests, urinalysis, skin biopsies, and nothing was really turning up other than he had, a series of biomarkers that were off, extremely off. There was one test that kept coming back that said creatinine levels are extremely low, could skew results. And I definitely glommed onto that. I knew what creatine was because I'd had a friend who took it in college as a sports player. And I continued to ask questions about creatine, not really knowing what I was asking for. And we were fortunate to get a diagnosis at an early age, thanks to Rady Children's Hospital and the physicians there. And but the damage was done. It's irreversible. And so that is, of course, why it's so important to have newborn screening. Next slide, please. So these are some pictures of Ty when he was first young, a baby. He, like I said, could not sit up. He was very little, and on the 0 percentile. And of course, this wasn't being tested for. Nobody really knew what it was. And so the things that we went through, we thought maybe it was mitochondrial. I'd had a really difficult delivery. We thought maybe he had cerebral palsy. And so we really spent our time looking at a lot of different things, but GAMT was not something that was very prevalent. As a matter of fact, I think Ty was one of the first 30 cases in the world when he was diagnosed back in 2006. Next slide, please. Tell you a little bit about our journey. I remember going to a physician appointment at 6 months and saying, he's not sitting up, I'm really worried. And after he had gone through a bunch of different, the pediatrician had gone through a lot of different tests and muscle movements, he said, I'm really concerned. And that started us on our journey. And we immediately went into physical therapy and occupational therapy as a baby. And then as Ty was diagnosed at 10 months old, we then moved into speech therapy. And here you can see he's doing horse therapy. And I can tell you that when Ty started receiving the treatment at 10 months old, it was as if a light bulb turned on. This little baby who couldn't sit up all of a sudden was standing up out of my lap within 1 week of treatment. And it was really miraculous. And the horse therapy, of course, helped with bringing on his speech and balance and movement. And we threw every type of therapy that we could at him because he had missed so many months of development. And it was just so important to kind of get him as quickly as possible caught up. Next slide, please. So Dr. Longo talked about the different therapies that we use. It can be done in a lot of different formulations. The creatine itself, it's a lot of medicine, but it's pretty easy as far as just taking it orally. There are some kids that choose to do the G-tubes, but the powder formula, creatine, if anyone's ever taken it, it's kind of gritty, doesn't have any flavor to it, but you do take massive amounts of it. But again, it's a safe and effective treatment. It's affordable. The L-ornithine, it has kind of a bitter taste to it. Now that my kids are older, I can encapsulate it and it's easier for them to take it. And we do the same thing with the sodium benzoate. It's in a capsule form. And the low protein diet, it's not extremely difficult. My son, who's 18, still eats 40 grams of protein approximately per day. And so it's not as difficult as some of the other rare diseases that require a low protein diet. They can still have a certain amount of protein per day, which is fantastic. Next slide, please. So as we talked about with the late diagnosis, the brain damage is irreversible. Again, showing the need for newborn screening. Ty was diagnosed at 10 months old, but today, as an 18-year-old, he still seeks and goes through speech therapy and occupational therapy. He has attention deficit issues. He at one time was diagnosed with having up to 100 absence seizures per day. So he takes treatment for seizures also. Here you see him in the hospital. He broke his finger. He was riding a bike. He doesn't really have that coordination. It's a real struggle for him. And he ran into a fence. We're not sure if he was having an absence seizure at the time. And then the learning disability is also there. This picture on the right, he's ironically wearing his GAMT t-shirt, but he had gotten onto a machine, and we said, make sure to take it slow. And he had it up to a 10, and sure enough, he fell off and bloodied his knees. And sometimes it's just a real slow learn, which is difficult. And he knows that he understands he is a little bit different now. Next slide, please. So as a late diagnosis, he definitely has gone through a lot. The EEGs are constant. He, being 18, he's watched his friends get their driver's licenses. I don't think he'll probably ever get his. We do EEGs constantly to see how he's doing and if he's improving and if we'll be able to go off his seizure treatment. At this point, we're keeping it intact because we feel like it's at risk of having some really terrible seizures beyond absence. So we keep him on the Keppra as of now. Next slide, please. And this is Paige. I always get a little emotional when I talk about Paige because here she is being a typical baby on the left. She was able to sit up, bang blocks, feed herself Cheerios. She is a typical teenager. She's a straight A student, and she had the good fortune of having an early diagnosis. I did take creatine while I was pregnant. As Dr. Longo pointed out, we felt like it would cross the placenta, and she came out just extremely typical, which we're super grateful for. And she's almost kind of a big sister to her big brother in a lot of ways. And she's just a wonderful student, a great kid, and extremely fortunate to have been diagnosed early. Next slide, please. This is some of Paige's favorite activities. She skis, she wakeboards, she plays soccer. She just made the high school soccer team. She plays golf. She plays volleyball. She plays water polo. I mean, there's just not a sport that she can't do. And she, like I mentioned, she's a straight A student, honor roll, honors classes. And she's just thriving because she had this early diagnosis. We're extremely proud of her. Next slide, please. So today we manage the guac. Pompeii has already taken the GAA. So we have been moving over to the term of guac for the guanidinoacetate, which is, of course, the neurotoxin, the buildup of guanidinoacetate in their brains. They do blood draws regularly. These are my kids. They jump up. They kind of get to argue about which one gets to go first. A blood draw is very simple, just to make sure that we're managing that guanidinoacetate properly. And as we change formulations or pharmacies, we make sure that they are on track. And they do still have an elevated guac, but we know that with early treatment, that it is seems to be okay. Next slide, please. Dr. Longo, Dr. Pasquale have both been integral in helping us get this onto the RESP. We went several times. The advisory committee, of course, as you all well know, has a very strict guidelines for what they are looking for to be able to approve something to be put onto the RESP. We were determined to do that. And so was Dr. Longo and Dr. Pasquale. They met us several times out in the DC area to speak with the advisory committee. And we just could not be more grateful to them for their work. There's been a lot of physicians that have put a lot of time and effort into helping us spread the word in newborn screening in different countries. And we're just so very, very thankful because they are literally saving lives as we speak. Next slide, please. And this is my family, and we spend a lot of time fundraising for the Association for Creatine Deficiencies. I want to do a quick plug, some of the things that we do, and I know that Terri mentioned this also, how important it is to put the patient advocacy group onto your site. That patient advocacy group, ours specifically, we can connect families. Sometimes we can geographically put them together. They have a support group. We have a really robust patient registry where obviously research can happen. They're informed about upcoming research projects and screening, and but that support for the families that I did not receive, that I want other families to receive when they first receive that diagnosis is so important. There's such an emotional toll on the whole family, but when they join the support group, they really do have this opportunity to connect with other families. And again, that patient registry is so important when you have an ultra rare disorder. And so we really encourage you all to share the information about the patient advocacy groups and that registry, and to make sure that we're capturing all that information that's important to companies as they move forward in trying to find even a better treatment. Next slide, please. As I kind of spoke about just now, that support group and connecting with experts, we have a lot of information that we send out, quarterly newsletters, of course. We have Ask the Experts, so our families can connect with physicians that are experts from around the world on how to treat for different symptoms. We even have a sibling support group where our siblings that are not affected can go to a safe space. It is broken up by age groups, and those siblings can talk openly and honestly about what's happening with their siblings, and it's age appropriate. We break them up into smaller groups of, those that are under 5 or those that are between 5 and 10. And then of course, our teenage groups that are also dealing with their either younger or older siblings that have the disease. And it's been fantastic for those families and support. We are also funding fellowships and research grants, and those have been very successful. And we're looking forward to the future of what we can do for better treatments, and then certainly a treatment for creatine transporter disorder. Next slide, please. I don't want to take too much more of all of your time. I think everyone has done a really good job with talking about the importance of the patient advocacy groups. Dr. Longo did a fantastic presentation, explanation of GAMT. I just want to thank all of you again for giving me the time to talk about my family's experience, but also how important the screening is for GAMT and newborn screening. So thank you very much.
So much, Kim. We really appreciate. Yeah. Well, folks, I know we're really off schedule, but we're going to continue. We're going to carry on. Hopefully, folks can stay with us. If not, this all will be recorded and put on our website for people to view the rest of it. And I'm going to go ahead and introduce Dr. Sharma. Dr. Rajesh Sharma is a clinical biochemical geneticist with more than 25 years experience in biochemical genetics and clinical chemistry. He is a ABMGG board-certified clinical biochemical geneticist and a fellow with the American College of Medical Genetics and Genomics. He joined GDSP last year as the chief of the Laboratory Services branch. Previously, he was the scientific director for the Department of Biochemical Genetics at Quest Diagnostics, Nichols in San Juan Capistrano. And prior to that, he was in charge of the Biochemical Genetics Unit in the Medical Genetics Department at Sargon Jaram Hospital in New Delhi. And welcome, Dr. Sharma. Dr. Sharma, are you with us? Are you able?
Can you hear me?
Now we can hear you, yes. Great.
Okay. Thank you so much, Tracy, for your nice introduction. But first of all, I will thank Kim. I have seen your emails, and thank you for your willingness to provide us consent to use the positive control samples. Really very helpful, validate our assays. So going back to my focus of the presentation will testing for these MPS II and GAMT deficiencies. I had prepared some overview slides, but after Dr. Harmatz and Dr. Longo, wonderful presentation, I don't think I have to those slides. So I will directly skip to our testing. So I will go to the MPS II 6 number slide. As Dr. Harmatz mentioned, for MPS II, in MPS II, both breakdown, there's a breakdown in heparin sulfate and dermatan sulfate, and pathway for both these are blocked. And before newborn screening, the MPS, these patients were identified by analyzing dermatan and heparin sulfate in the urine. And once we identified, we will do the enzyme analysis to confirm. And now, I think with the newborn screening, our approach is now different. We are detecting these babies in MPS babies through newborn screening. And once we identify them, we will confirm by and monitor them by sequencing analysis and monitor them by glycosamine glycan analysis, that is dermatan. So incidence of this disorder is MPS II is 1 in 170,000 in male, but in Japan and some part of Asia, incidence is 1 in 60,000. And in Japan, I think MPS II is much more common mucopolysaccharidosis than other. So MPS II newborn screening was approved because of Dr. Harmatz, I think, advocacy, and it was approved in 2022. And California, as you've seen Tracy's slide also, in California, our mandate is that once it is approved by Health Secretary, we get 2 years to bring this disorder in California. So we will be bringing this disorder live next month. And we have some experience that what we will be getting in California from experience from Illinois and Missouri. In Illinois, they are seeing at least 1.14 cases per 100,000. There are more pseudo deficiency cases they have seen, and same I think we will see in California also. Definitely for clinician, the concern is that they want to see the positive patient and they don't want to see pseudo deficiency. So we are working on different methodology part where we try to send only the real positive cases, but again, with the screening assay, we will be sending some of the cases that will be pseudodeficient and others. So our methodology is a two-tier approach. One is we are doing MPS II, and MPS II is a unique from the technology part of view. So right now, all the screening assay, we do direct mass spectrometry analysis. We shoot the sample through MS with a very brief, I think, analytical process. But for MPS II, it is a little different because since MPS II, I think, enzyme is the substrate for the enzyme associated with MPS I, we have to basically separate both the product for both the enzyme. And to do that, we have to introduce the chromatography step to separate these, and that have increased the I will say reproducibility for the assay and accuracy also, but at the same time, it has increased the turnaround time for this assay. So we have multiplexed this assay MPS II with our existing MPS I and Pompe assay. So you will see a performance, I think, quality performance on those assays also, because now we are doing. It is very similar to anytime you perform these assays in the diagnostic lab. So in the screening also, we are using a liquid mass spectrometry approach instead of a direct mass spectrometry approach. So second tier we will be doing molecular testing, and we have received many feedback from our clinicians. At the same time, we are also working on screening assay for glycosamine glycan also. So we will be live after. We have started working on it, but it will take at least a year to go live with the glycan assay. In the meantime, we will be working on to send out these assays to other labs. So our current approach is we are, as we said, we have multiplex by using commercially available reagents. We punch the blood spot, and the principle is very simple. I think we add the blood spot and we add the artificial substrate, and the product that is formed by combination of artificial substrate with the blood spot, that is basically we are measuring. So we measure this one. It takes for MPS II, takes the 18-hour incubation time. That is basically increasing our turnaround time also. So once the result is ready, I think on the screening assay we do the quality control check. We are running internal standard with every sample, and we run at least 5 plates, and we take the median of the samples, and we calculate the cutoff, 15% of the cutoff median, and we report any sample that is less than 15% as positive. We have a plan to we always do our cutoff after a year, or if we are seeing too many positive, we can do it before also. So all the presumptive positive are flagged for review and rerun, and if the sample is still below the cutoff, it is sent for sequencing. So this is our current method, that is flow injection analysis, directly sent to mass spec, but with the new method, with liquid chromatography, we will be separating the peaks very well. This is our current chromatogram from our new assay. We'll be separating Pompe, MPS II, and MPS I enzyme very well. This is our MPS II. On the left side, you will see the bottom is the internal standard, and here is the product MPS II. That is normal. You are seeing the peak, but in MPS II positive sample on the right-hand side, you are not. So this way, we are identifying our MPS II so far we have run more than 1,500 patients, and out of those we have also ran at 5 positive samples from our advocacy groups also. And our diagnostic algorithm is we will do our LC-MS/MS is the first year assay. If it is positive, we will send for a DNA testing. And at the same time, we are also planning to do glycans testing also. And once that is positive, then confirmation is done by the diagnostic lab by glycan testing and enzyme testing. Now shifting the gear to Guanidinoacetate methyltransferase deficiency. Again, Dr. Longo has done a great job in presenting, so I will skip these slides. So if you see in guanidinoacetate, as Dr. Longo also in his slide, GAMT guanidinoacetate GAC is elevated, creatine is low, but you will also see when we will identify these patients, there will be a time where you will also see, we will also identify AGAT patient also along with GAMT patient. Because in GAMT it is elevated and AGAT patient it is extremely low. So RUS approved GAMT on last year, and California will add it at the same time with the MPS II. So we have some experience from New York and Utah also, and we are expecting we will see 3.2 cases per 100,000 when we see. So we will be seeing at least 12 to 15 cases every year, screen positive. And there's possibility, we don't know and we should see, I think, 1 to 5 confirmed positive cases every year. So Dr. Longo has already covered our first year. We are using 2-tier approach for screening for our assays. In first year assay is our flow injection analysis. That is a easy method. But anything that is positive in our first year assay, we will be doing second-tier assay to confirm the first-year positive cases. So our first-year approach is flow injection analysis, and second-tier assay is LC-MS/MS. And our algorithm for approach will be anytime that first year is positive, that is more than 2.5 micromolar. We will check the ratio also. If the ratio is more than 10, then it will be sent for a second-tier testing. And in the second-tier testing, if it is less than 5 micromolar, it will be negative. But if it's more than 5 micromolar, we will report at the screen. So there are many people who are involved in this assay, and I'm very thankful for all the teamwork at our laboratory that staff has played in developing these assays. And after and I will shift now to Tracey. Tracey, I will leave on you to do the last part.
All right. Yeah. Thanks so much, Dr. Sharma. So, I'm next. I guess I got to share.
You're fine, Tracey. Donna's sharing.
Yeah. Oh. Good. So she's got our slides up. So I'm going to go through this quickly. Hopefully everyone can hang in, and hopefully folks can stay around a little bit to get a chance to ask some questions. But obviously we have to add our 2 new conditions to our SIS system, and it'll follow the current flow. So both GAMT and MPS II will show up as headline cases in SIS after their second-tier testing. There will be new tracking events in our system specifically for our new disorders. And but for the mechanism to refer in the system to the special care centers, we will use the current tracking event that we use to refer to the metabolic centers because we already have an excellent relationship with you guys. Next slide. All right. Obviously, we need new metabolic service reports, and we have new ones for GAMT and MPS. I just wanted to mention there's been a lot of, when we did MPS I, I think we have 5 or 6 resolution categories, and we've simplified it for MPS II. So thank you to those who helped us and provided feedback, and hopefully it'll be easier for people. And obviously, we're always open to conversation. So if that doesn't work for folks, we can discuss. Next slide. In addition, obviously, we have new annual patient summaries, and they will be new. So on the screen, you know, there's a drop-down. You choose what disorder you're doing an annual patient summary for. And an annual patient summary for those who are new with us is our long-term follow-up mechanism. This is where the special care clinic staff provide us information on how these patients are doing it. And we ask for a report once a year for the first 5 years of their life. And again, they're new. I solicited some advice for content. Thank you very much to those who were able to provide content for me. And, you know, again, a work in progress. If there are symptoms that we've forgotten or a new treatment is available, you know, we can add them to the system. Next. In addition, we've made minor modifications to the mailers. Primary reason being that we needed more room. So we have removed text from the. Am I showing or is she showing? Yeah. Do it. Oh, okay. Sorry about that, folks. I didn't know they were showing. Back to the mailers. So we had, in addition to the, you know, the values on the result mailers, we added, we've taken away the text that used to be there for the lysosomal diseases and for ALD. So that is gone. So we could have room to add our new analytes. And we think it'll be a good thing, and it's kind of part of our plan as we move forward with changing our SIS system, which I won't talk about a lot today, except to, before I end, solicit everyone's assistance in giving feedback on what we want to do with our new system. But so we'll see how that goes. And we also decided if Tier 2 for GAMT is run, we're not going to show the Tier 2 results. So we will only show the result that is responsible for the screen positive determination. So we'll see how that goes too. Next slide. As many of you know, we have had issues with our confirmatory contracts, but we continue to press forward. Mindy Zale is really working hard on this, so a shout out to her and thank you. We have been able to secure a contract with Quest to run testing for GAMT. So come July, you will be able to order the Creatine Biosynthesis Disorder Panel urine through Quest, and you'll be able to do that through SIS like you do for the MSMS conditions. We've been working with labs to find testing for all of our MPS. We're currently working with Greenwood Genetics in South Carolina to see if they will have a contract with us. You know, lots of legal back and forth between the state legal team and the lab's legal team, and you know, the state wants a lot of bureaucratic language in the contract, which they don't like. So we continue to press forward, and hopefully we'll have good news soon. Next slide. communication and education. So we have designed information sheets, one for the family and one for pediatricians, with basic information about our new conditions, sheets for both conditions. They're not intended to provide substantive education about these conditions. For the parents, it's more along the lines of, your baby is screen positive, more testing is needed, you need to see a specialist, and just, recommendation to follow instructions that have been given and discuss things with their pediatrician and specialist. The pediatrician sheet has a little more clinical information, but, it's, again, kind of more just-in-time information, and both sheets have appropriate web resources, right? It doesn't do any good to tell somebody not to go on the web, right? You need to give them appropriate resources. So for families, Baby's First Test and HRSA has designed a very nice sheet. And for pediatricians, the HRSA site, Baby's First Test, and Medline, we suggest those. In addition, at some point, these will be available on our website, too. Next slide. Questions about, so we're missing a slide. I will send it. Unfortunately, it seems we're missing a slide. I want to give a shout out to Kristen McKay from Project Alive. This program has been very long today, but we've recently been in contact, and they offer wonderful support resources for Hunter syndrome too. So we will make sure that their resources are provided on our website and to the metabolic centers to pass on to families who are diagnosed. So with that, if everyone has some time and is willing, why don't we open it up for questions? I am going to ask, if you have a question, to please put your hand up by the reactions and unmute yourself.
I think there are some questions in the chat.
What?
Check the chat.
Check the chat, too. We will start there. And I'm sure there are tons. Okay. Aside from all the thank yous, the first question I see is, are these both CCS eligible, and will they cover supplements for GAMT? And then she asked, this was earlier, so what are the follow-up tests, and are they covered? The tests will be covered. As I said, we are working on having the program actually be able to pay for the confirmatory testing, and that should be able to be done through GAMT, and we're working on the MPS. So this will be like any of the other newborn screening conditions. So they, as newborn screening conditions, they are automatically CCS eligible. That does not mean the process is easy or goes smoothly, but they will be eligible. And definitely for all the diagnostic testings and for treatment. I do not know specifically supplements. I know that sometimes with CCS, if something is available over the counter, like a biotin or a creatine, there might be some back and forth. But I believe they should be. We can double check with CCS, with Dr. Abramson, and provide you more information. Will the urine GAG test use an NRE method? And I'm not sure whether Dr. Wong is asking about the confirmatory that will be ordered out or ours. to clarify, we are starting the process of being able to run GAGs ourselves, but we're not coming live with this, and it's going to take a bit to do that. So that will not be part of screening in the immediate future. So I can either ask Dr. Sharma to chime in, or we can hold that off until the assay is developed and he can explain it all to you in detail when the time comes.
Yes, it is a non-reducing end method, but it will take time. As it will, we anticipate with the CIS new update, it will take more than a year at least.
Okay, thank you.
Okay. Yeah. Which lab will be doing the genetic testing? It will be going to Revity Osmotics. The same with MPS I, MPS II, and ALD. They are doing our third tier for the metabolic for us.
And Tracey, one of the question I think is from Dr. Feigenbaum about AGAT deficiency. Yes, we can detect it, but we have not figured out how we'll report it out. Is that correct?
Correct. I just see that question too. Yes, we have not set up our system to call out AGAT deficiency.
Just to add to Derek's question, urine GAG is not really considered a second tier. It's blood GAG that is the second tier.
Yeah, of course. Yeah.
Yeah.
The GAGs we develop in-house will be on the NBS spot.
Yes.
Dr. Sharma, you've been working with Mike, right?
Yes. I think we are working, and again, it will be on plus spot.
Okay. Anne-Marie Roberts, our dietitian in the Central Valley, says she's had good success paying for creatine for patients. So excellent. Uses the VitaFlow package with an NDC number. Well, MPS II and GAMT calls out only on newborns born after July 22nd. Yes, in fact, it's not even birth date, it's test date. So any baby whose sample arrives at the laboratory starting on July 22nd will be tested for our new disorders. We are not going backwards with these. We have got ourselves up and going before the legislative deadline, so we're in good shape. We have a biochemical fail for MPS III, but normal sequencing. Will those results be suppressed or reported? I'm not sure what David Dymack means by that. Dr. Sharma, does that question hit you?
If we have David, can you explain what? Sorry, we didn't get it.
So supposing somebody has an abnormal newborn screen for biochemically for MPS II, so they look like they have it, but they have normal sequencing on the reflex to sequencing, will those results be reported out, or are we just trusting that the negative predictive value of the sequencing is good enough that we would never see those results?
Most likely, I think if sequencing results are negative, most likely you will not be, I think,
it will be reported out as negative. It would not be screen positive. Gotcha. Okay.
Yeah, it will be screen negative then.
Yeah. And then our genetic counselor, Ayaka Suzuki at UC Davis, asked where will the second tier be done until the testing. It won't be. This is not being done through the program. So first tier is going to be the MSMS with the enzyme that is multiplexed with the other LSDs, and we'll go straight to molecular testing like we do for MPS I and Pompe. GAGs that we're trying to get paid for will be considered confirmatory on a new blood spot that will be sent to whatever lab we can get a contract with.
And going back to David's question, I think, David, you are mainly worried about for some of the other pseudodeficiencies or other cases where GALB is telling that you can miss those cases. So I think those cases, I think if the first year, if biochemical is positive, molecular is negative, then we will call as a negative. But once we start doing GAGs, I think if we find something else, then definitely we will start reporting. But till then, I think our will be, if it's negative here, positive here, and negative in the sequencing, then we will be reporting as a negative. But if you want to give us your feedback, what exactly you are looking for.
Yeah, I mean, I know for a lot of conditions we've had false negatives with sequencing, and I would have a degree of anxiety that we would miss a case, especially if there might be an intronic variant or something that is common in one of our less well-studied populations. I just would have anxiety that we would miss a diagnosis by relying on sequencing to exclude the diagnosis.
So what you propose? And we can set up I will set up another meeting also. We can discuss in that also, but
I would agree with David. I would agree with David's concern. Consider reporting that out.
Yeah, and I agree as well. I do have a patient who with negative genetic testing is older, so he has an attenuated form, but he's benefiting very much from therapy. So the way to do would be to proceed with the referral. I mean, or maybe do a repeat a newborn screening blood spot, and then if the repeat blood spot is still positive for the enzyme, to refer to a medical center to defer them what to do.
Okay. No, thank you so much, Dr. Longo. We will work on it. And we agree, I think, but let's work on the logistic from our end. Tracey, what do you think?
Financial too. Okay, we will continue the conversation. Yeah.
Yes.
Yeah. Allison, one of our ASC coordinators, asks if the specialist would like the first-year results. Is that something we would have access to provide? And yes, it will be in CIS. It just won't be on the mailer for space reasons. And I assume you're talking about the GAMT, yeah. Excuse me. And Dr. Feigenbaum asks, will the Revity lab give us direction for, RE mutation, severe, attenuated? And I think my answer, they do for MPS I. So my answer probably to the best of their ability, right? If they have information about the variants, I assume they will share it with us. And when we have conversations with them, we can make sure that that's on their plate, that they understand that. Anyone else? I'm going to ask a real quick question to Dr. Harmatz and Dr. Longo. So this is all probably going to be happening in the first few weeks of life. So Dr. Harmatz is in the room. I'll start with him. So what might you order? So, the confirmatory tests come back, right? There's a known, pathogenic mutations. What kind of things would be ordered in that immediate period? Would you wait for symptoms, or would you go, start MRIs and the whole workup?
In the case of GAMT, what I would do biochemical testing. Is that if persistently abnormal, I start therapy. I don't wait on mutation.
Okay.
And Dr. Longo, can you share your experience on AGAT deficiency also? I think I spoke to Margia.
Not on the newborn screening. So, but what I would look, I would put a low cutoff there as well. So just to make sure that you keep an eye on it. Usually they're very highly clustered, and again, guanidinoacetate is what it is lowest. creatine can be totally normal, but guanidinoacetate is non-existent, is close to zero in a GAT. So, but let's see how it is the performance of the lab and what is the lower limit of quantitation. That it is what it is important to determine. So once you have that in your hand, after a year you may start looking for lower values.
Our LOQ is very low, I will say. We can detect very well, I think, the low cases. And since we are doing second tier, I think assay is a little bit more robust. I will say it's still not diagnostic, but it is very close to, I will say, we are in that arena.
Or MPS II would be similar. You would start with your biochemistry and try to do it. Repeat, look at your urine GAG, see the level of elevation. If it's a well-timed pathologic mutation, you're probably going to move towards evaluation and treatment. The U.S. or likely pathogenic, you might decide to watch. And MRI would be far down the list. It would probably be bone films and cardiac exam and following the patient.
So is it real that in the algorithm, in the follow-up of GAT, this urine testing at 12, I mean, urine, creatine and guanidinoacetate should not be done. Plasma should be done. The second thing, remember, getting urine in a baby is very hard. Getting plasma is very easy.
For the MPS II, I was reading the sooner the enzyme therapy can begin, you're thinking you might cause the symptoms or alleviate. So, yeah, how do you time when you would start the enzyme therapy?
Barbara Burton's last paper is probably the most helpful, where she really looked in detail at the 9 positives, and 4 she felt were neuronopathic that you would start right away, and 4 were attenuated. And ideally, MPS II, you may find, you look at other family members who you'll get a hint, you'll find some 40, 50-year-old uncle who's just developed some symptom, and she's probably not going to advocate treatment. She has guidelines. There have been a couple of Delphi rounds trying to get some guidelines out on how to take care of it, but there's a big there was about 50% were attenuated that you could possibly hold off, and yet they had urine heparin sulfate 200 with 5 as the normal cutoff, and yet she's deciding they're based on family history that they have milder disease. You don't have to rush, or you may not even be able to follow patients with that much disease. So it's really separating that 4, and I think the molecular is you have a severe mutation. You've got a really good predictor. You have to move forward, and it's a hard decision. It'll be hard when we have better therapies that penetrate the brain, and you can start and treat.
Thank you.
Tracey, I believe there's a question about urine versus plasma guanidinoacetate.
I think there was some confusion. I'm sorry. The acylcarnitine or the creatine panel testing at Quest will be blood. I apologize if I said urine, but it will be blood. So that was probably me who messed that up. But it is blood. Yes, the urine is the GAGs for MPS.
Hi, thank you for that clarification. Do you know the title of the test? Is it just the plasma creatine guanidoacetic? Is that the specific panel at Quest?
It is called, where is that?
Or the test number?
Anymore, but
just to confirm.
and we will send all this out. It's the Creatine Biosynthesis Disorder Panel. Oh, I said urine though.
Mm-hmm.
They
Yeah,
have
the slide
urine
stated
also.
urine.
We'll have to talk to Quest.
Okay, appreciate that clarification. Thank you.
Yeah. Other questions? If not, I appreciate everyone's time. We have gone way over, but hopefully it was all good information. I appreciate everything. We will send out notes. We will send out link to the recording. Please, if Sona, you want to share the slides again to give them the CME scan. Or if you're interested in CMEs, please go ahead and fill out the evaluation and send it to us. We will get notes and the link to everybody. And I will ask our presenters, but I assume our presenters will have no problem with us providing their contact information if you have further questions. So thank you, everyone. Take care. Have a great rest of your day.
Thank you. Yeah, okay, I definitely.